Good day, everyone. Welcome to the 0 to 3 Impacting Infant Mortality through Home Visiting conference call. Today's call is being recorded. At this time, I would like to turn the conference over to Susan Stewart. Please go ahead.
Thank you very much, and welcome everybody to this is our October webinar sponsored by the MCV Technical Assistance Coordinating Center. And our focus today appears to be a topic of great interest to you all. We've got a lot of folks on the line today, and the focus will be on impacting infant mortality through home visiting. And we have staff from the Association of the Maternal and Child Health Programs. Specifically, Dr. Michael Fraser will be our presenter today. And there's a few things that I want to remind you about before we get underway. The first is that the MCV TAC, or Technical Assistance Coordinating Center, is funded by HRSA, and it is housed at 0 to 3. And the TAC partners include Chapin Hall, the Association of Maternal and Child Health Programs, or AMCHP, and the Walter R. McDonald and Associates Incorporated, which is also known as WRMA. And as you probably already know, the TAC provides all kinds of supports, different levels of supports to MCV grantees using 0 to 3 and their partner staff, along with expert consultants, as well as in coordination with other TA providers. So lots of resources available to you. By the end of today's webinar, we're hoping that you'll have had a chance to learn about the national priorities for improving birth outcomes and have a greater understanding of several comprehensive strategies to address infant mortality. We hope that you'll learn a bit about the AMCHP Birth Outcomes Compendium, which really is an excellent resource for policies and state program options for addressing infant mortality very systematically. And then we hope that you will consider how specific home visiting practices and policies can be used to improve birth outcomes and reduce infant mortality. So hopefully you will have all of those happening by the end of the webinar. And I did want to let you know that currently your telephones are muted, and we do encourage you to use your telephone over your computer speakers. Today we're going to have an opportunity for your lines to be unmuted, and we will allow you to share your thoughts by phone as well as chat. So if you're listening on your computers, you won't be able to participate verbally if you also don't have the telephone, but you will be able to chat throughout the entire time. And speaking of chat, really want to encourage you that chat is not just for Q&A time. You may submit your comments and questions at any time, and on the screen you see a screenshot of where the chat box is, and it's in the lower left of the iLink window, and you will want to type your message in the field, the text field at the bottom of that box, and then click the arrow on the iLink window, or you can hit enter on your computer keyboard, and that will send your message up into the public chat area where everyone can see it. Also, you should have received an email with a link to the PowerPoint slides. If you have not received that yet, don't worry, it will be coming to you later today, so you will have those to access. And now, I would like to introduce to you Josephine Ansa, who is a public health analyst with HRSA, and she's in the Home Visiting and Early Childhood Systems Division. And she's dropped by to welcome you to today's webinar. Josephine?
Great. Thank you, Susan. Greetings, everyone. On behalf of HRSA's Maternal and Child Health Bureau and the Administration for Children and Families, I would also like to welcome you to today's webinar. As we're all aware, the infant mortality rate, the number of deaths occurring in the first year of life per 1,000 live births, is a widely used proxy for the health status of a nation. As we're also aware, the U.S. rate is among the highest among all developed countries, with persistent racial and ethnic disparities. But what continues to be inspiring is that there are amazing efforts at local, state, federal, national, and global levels, some of which will be discussed during today's webinar. HRSA and its partners are committed to addressing this issue and associated adverse birth outcomes and disparities by recognizing the historical, cultural, clinical, and social factors that impact women's health and the health of infants. What continues to be inspiring is that since the launch and implementation of the Maternal, Infant, and Early Childhood Home Visiting Program, state teams and stakeholders are also committed and have been very intentional in aligning home visiting and infant mortality reduction strategies, fully recognizing that home visiting is only one tool in the arsenal to effectively address this complex challenge. A few years ago, while involved in a community initiative with HRSA grantees, one of the grantee representatives described infant mortality work as a movement as opposed to an initiative or a program, and that description really resonated with me because at its core is collective responsibility. Thank you for your participation today and for all of your contributions in this movement, and I hope you enjoyed today's webinar.
Thank you so much, Josephine, for your warm welcome and also for giving us some more context for our discussion today. And now I would like to introduce to you our presenter for today. And our presenter is Dr. Michael Fraser. And he has over 15 years of public health agency and association experience supporting and serving federal, state, and local public health agencies. He's currently the Chief Executive Officer of the Cessation of Maternal and Child Health Programs in Washington, D.C. And during his tenure with AMCHP, the program has been nationally recognized for its work in supporting state and maternal and child health programs. Before he joined AMCHP, Dr. Fraser was the Senior Advisor and Deputy Executive Director of the National Association of County and Child Health Organizations, or NACHO. And prior to that, he was a Regional Program Manager for the Centers for Disease Control and Prevention and a Senior Staff Fellow at NACHO. That's incorrect. He was a Senior Staff Fellow at HRSA. He was a Senior Research Analyst and Program Manager at NACHO and a Research Scientist with Aspen Systems Corporation before he joined HRSA. So you can see that he has many years and much experience in this topic and related topics. Dr. Fraser, we thank you so much for joining us, and we look forward to what you have to share with us about how national and state initiatives are really making an impact on infant mortality. Go ahead.
Okay, thank you, and good afternoon, everybody, and good morning for those of you out in Alaska or Pacific friends. Welcome to the webinar this afternoon. It's a wonderful chance to share some of what we're doing here in Washington with you across the country and to learn from you across the country about how you're making the connection between home visitation and infant mortality as well as more generally improving birth outcomes. I really want to thank 0 to 3 and our friends at the TAC for their partnership with AMCHP. We do a lot together, and especially thank Susan for her help organizing and orchestrating my slides. And several members of our team here at AMCHP will be on. Tegan Callahan and Pia will be with us. Pia Hansen will be with us to facilitate some questions at the end. And this has just been a great team effort. So very much like you in the States, we, too, at your national organizations are partnering to move our shared agenda forward. AMCHP is the national association that represents state maternal and child health directors, and in most states, the state health department is administering the home visiting program, although that's not always the case in some states. And it's great to see some of our members, our Title V directors and partners in state MCH programs are on the call. And some new friends, too. So we're really pleased with the chance to reach out to you and share, again, some pretty current, relevant, and we hope interesting information with you about national efforts to improve birth outcomes. We're going to be using interactive technology, so if you're at a computer, you can participate in a couple polling questions. And we wanted to make sure that we test that out so that you know how to use it prior to our real question asking. So we just wanted to test it out with this sample question. If you're sitting at a computer, feel free to answer what your dream vacation is. Paris, France, Paris, Texas, Hawaii, or none of the above. And there was only could only choose 4 options, so this was our best attempt at that. We're going to let you answer the poll and get a sense of your feedback. And we have votes coming in right now. Unfortunately, I can tell how many are left to vote. So looks like y'all are getting the hang of it. And I'm seeing here that Paris, France is the front runner with none of the above close behind. So seems like this is in Hawaii, actually, is taking some lead here. So this is helpful in just making sure you know how to use the technology. Several of you have no opinion, it appears. So either you're not at a computer or the polling system isn't as easy as we thought. But we're going to gauge your feedback using this technology. So if you do have the chance to use it, it's fun. It's part of your our learning process here, and we look forward to your feedback moving forward. So with the new question here, I just wanted to test a little pre-test here in terms of how confident you feel about fitting your home visiting program into national efforts to improve birth outcomes. And we can't see who's answering this, so you're confidential, and we want to use it as a way of assessing your learning after the call. We will be asking the same question. So fortunately, we have a pretty good response here already of agrees. And it'll be nice then, because many of you are probably fluent with several of the things I'm going to talk about, and we can make some pretty strong connections at the end of our time together. But I am going to let you vote, since there's a few folks that have yet to respond, and we just want to make sure we're getting everybody's input here. But from what I can tell, over half agree that you feel confident that you can describe how your work with home visiting programs fits into national efforts to improve birth outcomes. And I'm hoping that number doesn't go down after my talk. Our purpose here is to build confidence and share some information about some pretty great stuff going on across the country. So with that said, it looks like about 73, or it's about a little under 75% of everybody on the call agrees that they're confident they can describe how their work in home visiting fits into national efforts to improve birth outcomes. And for those of you who neither agree or disagree entirely or are unsure, my hope is that you too will have the chance to learn, and at the end of the call feel confident that you can describe how your efforts in home visiting are linked to some of these national initiatives. All right, thanks for that. I'm going to skip this slide. We just sort of measured that. The issue of infant mortality prevention and improving birth outcomes has received a lot of attention in the maternal and child health community, obviously, for a very long time, and has received some new interest over the past couple years. But those of us who've been working in public health and maternal and child health know that infant mortality is leading health indicator, and we're going to share that in a minute. But efforts to address infant mortality really sometimes feel like trying to sweep up sand on the beach. We are constantly trying new solutions, looking for new solutions, analyzing data, hoping to better understand the causes of infant mortality. And a lot of us in maternal and child health keep on going, and it's an overwhelming task in many places to address all the features and programs and issues that go into infant mortality and improving birth outcomes. Some of us feel like washing windows on an office building. Just by the time we think we've finished, got them all clean, ready to go, we have to start all over again. And so it's really tough to re-energize and feel confident that we're making a difference when we're oftentimes confronting a problem that feels like we're rolling a boulder uphill. This is Sisyphus, a Greek myth that Sisyphus was condemned to continue to roll a boulder up a hill. And gosh, sometimes it feels like we're rolling boulders up hills when we address the problem of infant mortality. And I just want to remind us that we're actually seeing some great success in reducing infant mortality nationwide. We're seeing pockets of improvement and overall decline in infant mortality. Here's just one example locally to us here in Washington. On the front page of our Washington Post several months ago was a story about infant mortality rates being at a historic low here in the district, which many of you familiar with the district know that it's a challenging place to do this kind of work and requires all kinds of innovative approaches, including home visiting, to make a dent in rates. And certainly we're seeing equal success in many other places across the country, and we can share some of those at the end of the call. But I also want to remind us that as we're seeing success, one of the biggest issues within as a subtopic within infant mortality is the race and ethnic disparities that we see in infant mortality across the country. And again, while we're making some pretty significant improvements in our rates, and this is an older slide, and I know we're getting better, but that gap between white, black, and Hispanic is pretty persistent if you look at the shape or the slope of those lines, and should be cause for all of us to redouble our efforts to address infant mortality in our work as maternal and child health professionals and people that care about kids. So as we talk about the infant mortality rate, we really have to keep in mind the race and ethnic disparity in the rate and just how locally driven this really is in different places across the country. And I'm working nationally, and a lot of what we shared today will be information about national initiatives, but it is indeed the case that solutions to this problem, like the way your home visiting program operates, are going to need to be tailored to the specific conditions of the sites and the communities in which you find yourselves working. Last year, about this time, there was a huge discussion in USA Today about the U.S.'s infant mortality rate and whether we're 41st in the world or 41st among developing countries or 39th or 29th or 33rd, and the controversy here being U.S. is 41st among developing countries, and the counterpoint to that was, well, it's because we count it differently than other countries, and just a lot of going on about the rate. And we had the chance at AMCHP to contribute a letter to the editor, which basically said, listen, we're not number one when it comes to infant death and birth outcomes, and we're certainly not number 10, and we're not even 20th among developing countries. This is a big problem for us in the richest country in the world that spends the most on health care in the world, and the solutions to the infant mortality problem here in the U.S. are complicated. The problem is big, and it doesn't matter if we're 41st, 33rd, or 29th. It's a shame that we're not first among peer nations in how well we're doing by our babies. And this isn't a medical problem. It's not a solely public health problem. It's not solely an economic problem. It's not solely an education problem. It's all of our problem. And part of what we are trying to address in the initiatives that I'm going to be sharing with you and discussing at the end is that perspective that a multi-sector approach to infant mortality that involves partners at many different levels and in many different professions is going to be where we find the answer. And you that work in home visiting do that work by cross-cutting education, health, maternal and child health, public health, health care, and all of those related resources that families so desperately need to address these conditions and improve birth outcomes in communities. So you know this all too well. And again, as I mentioned, the solutions to infant mortality are going to be different across the country, and home visiting programs are going to be, while consistent with certain models, obviously have different flavors depending on where they are. Nationwide, the National Healthy People 2020 indicators lay out goals for the states and for us to reach as a country. And the rate that's in the Healthy People 2020 most current edition, 2020, is 6. And we're currently going to be well on our way to reach that 6 infant deaths per 1,000 live births. I think we're currently, just from some data that I was looking at a little bit earlier, at about 6.4. And, over the next 6 to 7 years with the declines that we're seeing, we may well meet this target before 2020, which is great news for all of us, but again, really does mask some of those pretty substantial disparities in rates. Many of us are familiar with some pretty big initiatives going on, and I just wanted to share our perspective from where we sit at AMCHP and from where the states are, and what some of these big initiatives are. Talk a little bit about the resources that we're providing to states, and then have a conversation with you about what you think and what you're doing in your areas. Certainly, the March of Dimes, your state chapter, and also the National Office of March of Dimes, has committed itself to the issue of prematurity and has led a number of efforts nationwide to deal with prematurity rates and lower them, and a huge campaign called Healthy Babies Are Worth the Wait is taking place across the country. And I would certainly refer you to the March of Dimes website and all the work that they're doing with states to address prematurity prevention. And the reason why that's relevant, obviously, is we do see a lot of underweight babies experience adverse events, and obviously prematurity is correlated with infant death, depending on a number of different factors. But the Healthy Babies Worth the Wait campaign truly has shown some great success in the states where it's been adopted. And the resources and tools that are part of that Healthy Babies Are Worth the Wait campaign is something that I would refer you all to, and certainly can be a great resource, reference, and tool for you in your work. Similarly, the issue of prematurity prevention and even more specifically limiting elective deliveries prior to 39 weeks is both part of the Healthy Babies Worth the Wait campaign and March of Dimes, but also part of the ASTHO, the Association of State and Territorial Health Officials, President's Challenge. Over the past year, 49 states and most of the territories signed on to a pledge to reduce prematurity in their states by 8%. And ASTHO has committed itself to supporting state health departments with its partners in meeting that challenge, and we'll be monitoring with our state members and partners at ASTHO and others to see how well we're doing in meeting that Healthy Babies Challenge. But you can find more information about their initiative, which is obviously related to the topic at hand, on the ASTHO website, as well as a best practices resource that they've created, which is shown here on the slide on their website. So you can click on each of those boxes and find resources for improving birth outcomes at various stages of a child's life, as well as preconception health and some of the interventions that we are all very excited about to improve women's health, with the assumption that healthy women are more likely to have healthy babies, and getting to folks before making the choice to get pregnant and assuring that they have optimal health prior to pregnancy should they choose to become pregnant is a key piece of current efforts to address infant mortality. And what's exciting about these efforts is working with young women and women of reproductive age, as well as across family life, to improve health of everybody in the family, not just address the 9 months prior to delivery in the preterm period, which is obviously important, but we know so much of what drives birth outcomes happens early in a woman's life and is part of that family system that evolves over time. And for us to really make a dent in our birth outcomes, we have to take a much more upstream approach to the issue of infant mortality. And that's something to think about in your home visitation program, in the sense of, how are you preparing women both preconception but also interconceptually for healthy birth outcomes and healthy pregnancies moving forward? A key piece of all your work, I'm sure. Clearly, one of the major partners with us, and they might say we have with them, and is introduced earlier by our colleagues at the Maternal and Child Health Bureau, is the Maternal and Child Health Bureau, which has for many, many years supported state efforts to address infant mortality. A key mechanism for that is the Title V Maternal and Child Health Services Block Grant, which is Title V of the Social Security Act. And its new provision within Title V, the new provision that authorizes the home visiting program. So legislatively, it's exciting to see that Title V is the locus for both the traditional MCH work that states have been doing for many, many years through the Title V MCH Services Block Grant, but also seen as the more contemporary place through the authorization of the MCHP program and the provision that states receive dollars for home visiting, that huge expansion that was part of the Affordable Care Act. So we've been working primarily with HRSA, but colleagues also in partner agencies and the co-lead at ACF and their colleagues to make the connection to home visiting and infant mortality prevention, improving birth outcomes. And certainly the HRSA work that's going on has supported much of this moving forward. And HRSA has recommitted itself over the past year to support state efforts to improve birth outcomes, and primarily through an initiative that started in Regions 4 and 6 called the Collaborative Improvement and Innovation Network to Reduce Infant Mortality. It's referred to as the COIN, and it is a collaborative, obviously, in the title, effort that brings state leaders together in multiple sectors, both state health department, Medicaid, hospitals, providers, community groups, individual facilities, to address the issue of improving birth outcomes in their state. And the initiative started in Regions 4 and 6 primarily because it was Regions 4 and 6 that came together and said, we have a significant problem in addressing birth outcomes in our regions. It's historic. Regions 4 and 6 are primarily the southern states and the southwestern states where we do see large numbers in high rates of infant mortality, and we know that with some increased activity, we'd be able to make a dent in these, and that was the impetus to form the COIN. And because the COIN has been so successful in its initial phases, it's our understanding, and we're waiting for more formal discussion of this, but a similar kind of program will be rolled out both in Region 5 relatively soon, but hopefully by next year in all the states. So that's something to keep in touch about and to track moving forward. The key features of many of these efforts, there's several of them, and part of what we want to do today is just share with you what some of those key features are. Clearly, the main thrust of a lot of these initiatives is reducing elective delivery before 39 weeks. And you see that in the March of Dimes, Healthy Babies Worth the Wait. But also, this is a central part of the COIN effort to address state policy, both hard stops on Medicaid payments, for example, as a policy change at the state level, but also in changing patient demand and consumer involvement and everything in between. So a main part of the COIN collaborative is to think about what this looks like at the state level and, by extension, at the local and community level. Another key focus area of the COIN teams in Regions 4 and 6 has been to promote smoking cessation during pregnancy. We know that maternal exposure to tobacco smoke and both secondhand but also mom smoking being the primary smoker does lead to poor birth outcomes, which include infant mortality, and we know that there are a lot of options for smoking cessation available in the states, and this has been an important part of the COIN sharing, which is thinking through how do we make tobacco cessation more available and move up the number of moms who quit smoking or enter pregnancy having quit smoking or not being exposed to tobacco smoke at all. Certainly, we've seen some great success with safe sleep and SIDS and SUID prevention. We also know that there is a continued need for safe sleep programs, not just a back-to-sleep program, and that this is a controversial area for many of us in MCH, and also one that communities deal with differently and have different cultural and historical reasons, traditional reasons for co-sleeping, or we know that, for example, that there are a number of places where that's seen as acceptable And part of what we're doing is trying to find the interventions that work the best, that are community-driven and acceptable to folks so that we can promote safe sleep. And the COIN states are working specifically on this as a topic area as well. And certainly there's been a renewed emphasis on promoting perinatal regionalization and having moms deliver in facilities that have the appropriate technology. And this is a place where there's a lot of collaboration required both at the local facility level but also at the state policy level, and certainly a place where you may see more work moving forward as states really begin to re-energize efforts that had started, I believe, in the 80s and 90s and may have lagged off in some places. But again, efforts to promote perinatal regionalization are a big part of what the COIN is working on and an important strategy that we all have in assuring us better birth outcomes. In addition to the COIN work that's going on at the Maternal and Child Health Bureau, in June, Secretary Sebelius announced a national effort to address the issue of infant mortality. There have been a number of state efforts, state reports and state task forces, state commissions and blue ribbon panels to address the topic of infant mortality, but there's never been a national plan. And the Secretary committed the resources of HHS and the leadership of its related organizations to forward a national infant mortality plan that's currently under development and being led by the Secretary's Advisory Committee on Infant Mortality. And so obviously we're watching that, and we're part of the work to assure that state programs are a piece and included in the Secretary's initiative, which cross-cuts many of, as I mentioned, the operating divisions within HHS, including HRSA, CDC, ACF, Indian Health Service, and CMS, obviously. So there's a huge initiative underway through the COIN, through the Secretary's Advisory Committee as an umbrella to address this issue. And obviously, the biggest payer for births in the U.S. is CMS. It most likely will continue to be, especially with the Medicaid expansions we're seeing in some states and the implementation of health reform. And more exciting, we've also seen the introduction of the Strong Start initiative through CMS to identify innovative and cost-effective models for improving birth outcomes. And that, again, is tied into the work of infant mortality prevention. And while those awards haven't been announced yet, the folks are very anxious to have them be announced and start work in those models. And that includes home visiting as a strategy to improve pregnancy outcomes. And really exciting to watch that evolve through CMS. So given all these initiatives, the 5 big ones I just mentioned, I just wanted to take the pulse of you all listening. Have you heard or do you know something about even just general awareness of all of these efforts, of one of them, the COIN, the Strong Start, the Secretary's Initiative, the ASFO President's Challenge, or the March to Dimes Healthy Babies Worth the Wait? And I'm just going to take a break and see how the poll goes. And for those of you who are typing in questions, that's great. Keep them coming. We will get to them. And they're all good ones, so thank you. So what's fun to see is you've heard about, on average, our most frequent category is the 1 to 2, and with most of you voting. And what's also nice is many of you have an awareness of all of the ones I just mentioned. That's good to see too, and we're again looking to see how you're making sense of these various efforts in your states and in your work, home visiting programs in the communities across the country. Those were just 5 initiatives. This slide, which I know you can't read very well, is an inventory of other efforts at the national level by professional organizations like ours or government agencies that are addressing the issue of infant mortality, prematurity, and improving birth outcomes. And you can see that even though you can't see the names, you can see how many lines there are. There's over 40 initiatives to improve birth outcomes, including address the issue of infant mortality across the country, and this is not an exhaustive list. So what's important to know is there's a tremendous energy here and a tremendous resource going into the issue, and part of what we have to do is really take advantage of these opportunities to make the link and share our expertise, moving them all forward. And they all have some common features which I want to share. The core features of these national initiatives are, I think, important for us to remember as we approach our work in linking home visiting programs with some of these strategies. Quality improvement is a huge focus of many national initiatives, and certainly that includes public health, but has been really focused on care, and perinatal quality is a huge topic for many states, and there's a lot of perinatal quality collaboratives across the country that are working to improve birth outcomes and address the issue of infant mortality. We take, obviously, within public health a much more upstream approach, but all of it is informed by quality improvement and quality assurance. And we can be leaders in public health in the quality arena, certainly as folks that are accountable for health outcomes in our states. We all have an interest in doing the best we can with the resources that we have. Health promotion is another facet of the current work, and I hope you all have heard about Text for Baby. This is an example of kind of a modern way of doing health promotion that for many replaces leaving a brochure behind or doing a counseling visit, or adds to that. Certainly the health promotion messages aren't just for pregnant women, and there's a number of campaigns nationally within states to improve women's health prior to pregnancy and address health needs of women should they choose to become pregnant. So that's ongoing. This slide, which is on my screen a little a kilter here, but just we'll use it for illustration purposes, a number of federal programs out there to improve the health of women and children. And one of the things that we found a really important role that state maternal and child health programs play, but I'm sure your home visiting program, your early childhood councils and initiatives in the states, a big piece of what we're doing is trying to integrate all of those services available to families to improve health and well-being, home visiting being one of them, the block grant being another, but just a tremendous number of initiatives that have to be woven together, braided together to address birth outcomes. And that's a tremendous amount of work and can't be understated in terms of how much time it takes. But certainly there are resources there, and this is, I think, an important piece for folks to realize and to deal with. We've been dealing with infant mortality for a long time, as mentioned. Here's a slide from 1923 of early MCH epidemiology, infant mortality rates by father's earnings. I'm using this picture to illustrate that another central facet of the national initiatives and work that's been going on in the states has been a focus on data and surveillance and being able to accurately and in real time illustrate the extent of the problem in the states. So that's been another place where national efforts have focused. Another place where there's a tremendous need and national efforts have demonstrated a real urgent need for efforts in the state to be cross-cabinet, interagency, and include public-private collaboration. I use this slide of a state health department's break room to demonstrate that even in the agencies with which we work, we're not always collaborating or sharing. And certainly it's our hope that within the states, the work of the folks really focusing on infant mortality and the work of the home visiting program are integrated. But you can see here, like, these different coffee pots often reflect different programmatic silos and missed opportunities for collaboration and sharing across agencies and across sectors within a state or a community. I think what's exciting about the efforts on infant mortality prevention and improving birth outcomes that I've been sharing is the realization, which seems fairly obvious but wasn't always explicit, that these issues really are about improving women's health across the life course and preparing women for a healthy trajectory, whether they become pregnant or not. And you'll see in a number of these initiatives a tremendous focus on women's health writ large, which I think is really important and also very exciting. So of these different strategies, I can go back and share these again. Of these different strategies, quality, health promotion, service integration, data and surveillance, cross-cabinet, interagency, public-private collaboration, and focusing on women's health, of those strategies, how many of you are including at least one of those in your current efforts? We'll take a sec here to see how the responses are coming up. What's great to see is the majority of you already, I can tell from these data, are including at least 3 to 5 of them, most likely all of them, which is great. This is a group that knows what's going on nationally and is looking forward and including all of these strategies, which is wonderful to see. So our most frequent category here is A, 3 to 5. It looks like most of the folks that wanted to vote have. And certainly the 1 to 2 category is next with only 3 and 4 of C and D. So that's great. And keep it up. Your efforts are consistent with what's going on and being recommended nationally. Here at AMCHP, and this has been the work of our staff as well as members, collecting a number of different resources from states and surveying pretty much every state infant mortality task force recommendation and best practice that we could find. We developed a compendium to address birth outcomes, which is available online, and I'll talk about it in a minute. And that compendium, our survey of various efforts to improve birth outcomes and address infant mortality, has some core recommendations, and they echo what we've discussed prior, so I'll go through them relatively quickly. But the first recommendation in our synthesis of plans, state plans, as well as state best practices, it's really important, obviously, to implement health promotion efforts across the life course, and that's been shown in a number of these initiatives and certainly is a big piece of the work that you all do in your home visiting programs. Ensure quality health care for all women of reproductive age is another recommendation, and I think we have some tremendous opportunities in the expansion of publicly financed health care through health reform, as well as some of the women's health preventive services that are included in the Affordable Care Act, and other opportunities to ensure that women are receiving quality health care. And, for me, this is for all women, young women, not just women of reproductive age, but certainly that's what we're talking about, who we're talking about today. And I just want to refer you to a website. It's not live yet, but there's a wonderful resource that the state of Texas has developed called Someday Is Now, that is a campaign to get folks in Texas thinking about their health prior to pregnancy, both women, but also within families and relationships. And so as this, it's supposed to be live in middle of November. I was hoping it would be live prior to our call, but they're still working on the final kinks. This website is a resource for preconception health messages and how to think about preparing for pregnancy so that you have the best outcomes possible. It also has a father involvement component that I think is really exciting. And this is just an example of the kind of work that states are doing and thinking about with regards to infant mortality. Certainly implementing maternal risk screening for all women of reproductive age is a piece of the recommendations in our compendium. enhancing service integration, again, echoing what's going on in national initiatives. Improving access before, during, and after pregnancy with some pretty interesting things going on in Medicaid across the country. Developing data systems to understand and inform the work. And a real push not to be data historians, but to use real-time data to monitor progress and to change course as needed within a state. And that's a big challenge for many state programs. Promoting social equity, obviously we can't forget the disparities in infant mortality, and the opportunity for us here is to really move the needle, not just in infant mortality rates overall, but close and hopefully one day eliminate the gap between white and non-white infant mortality and birth outcomes moving forward. I wanted to share just a couple more thoughts, and then we'll turn it over for questions, getting close to the wrap-up here. This is a framework that we use in our compendium to help think about all the different kinds of interventions that are available to us in maternal and child health programs to address the topic of infant mortality. And a lot of the work in maternal and child health focuses in the counseling and education component, but that's just really the tip of the iceberg when it comes to the kinds of interventions or programs that can be implemented within a state to address any public health challenge, but in this case, infant mortality. Certainly, that one-on-one education and counseling is important, and that visit to a family that's looking for that support and is receptive to that education opportunity that's a great effort. But moving down the pyramid, you can see that there's also, in our toolbox should be programs and interventions that address these other levels, both the clinical, the protective interventions, but also efforts that involve policy change, changing the context in which individuals make health decisions, and more broad social economic change within communities and within states and ultimately across the country. And for us to truly make a dent in our infant mortality rates, we have to rely on interventions and programs at all levels of this health impact pyramid. We can't just expect a rapid change if we're focusing only on counseling and education or only on one of these levels of the health impact pyramid. The other piece is to think about the life course and think about how in our work we carry with us the health the influences on our health that we were created with and are exposed to as children, as young adults, as people of reproductive age, and as folks past that. And I love this slide image here, which shows, yes, as adults, we carry with us all that early programming and environmental exposure and the systems that we are part of into adulthood, and certainly that reproductive potential that we all have. And that, I think, paints a nice picture of why it's important to not just focus on 9 months of prenatal care or the 30 days postpartum, but instead take a much broader life course perspective in our work. The key features of all of this are that for us to address the issue of improving birth outcomes, we need to address women's health. We call this putting the W back in MCH, assuring access to quality care, both for women, their children, and families. Address all levels of the health impact pyramid so that our programs and interventions aren't just focused on individual counseling and education efforts per se, but cross-cut and go down the pyramid so that our reach is broad and involve communities and populations, not just patients. Integrate across silos and turf, and building capacity for data and research to show our programs work, but also for us to adjust our course if they're not. And that's been a really important feature for all of these efforts in the states, and I hope you're incorporating all these in your work in home visiting programs and associated and related events. For us to truly make a difference then, we really do have to take on the mantle of maternal and child health leadership. And maternal and child health leadership to us at AMCHP is, and maternal and child health leaders inspire and bring people together to achieve sustainable results to improve the lives of the MCH population. We care about moms, kids, fathers, and families. We care about the systems in which children thrive. We think about the maternal and child health as a population, not a program. And as MCH leaders, our job is to inspire, bring people together, and set a vision for what our community should look like and our best efforts to envision a healthy future for all moms and kids, and all fathers and families should be. So we need to take on that mantle of MCH leadership to move our shared agenda forward. Put those pieces together and be very wary of the challenges that we all face ahead, but not use those to limit us in our thinking or our vision setting. Instead, see those as opportunities. Certainly, there's a lot of challenge in the states right now. There's a lot of challenge in implementing the home visiting programs right now. But ultimately, we're all going to be accountable to shared success, and that's what we're trying to move forward here at AMCHP, and our members are trying to move forward in the states. So with that, let's do a quick post-test, and then we'll have time for a conversation. How confident do you feel now in efforts to describe how your work in home visiting fits within national efforts to improve birth outcomes? And we'll let you vote. And we're seeing some great numbers here. Thank you all. Almost everybody agrees. So earlier, our A category had 74 votes, and we've moved well past that, and we've gotten rid of our disagrees and unsures. So I think, Susan, we've met expectations here and shared some information that hopefully you can all use moving forward. Thank you for your time and participation in the slides here, and let's have a chance to hear from folks. After an hour of me talking, I'm sure you're ready for somebody else, and we can share what's been going on.
Great. Thank you so much, Michael. Lots of wonderful information, and I saw a lot of chatting going on about different programs and questions. And so I want to introduce folks to Pia Hansen and Tegan Callahan, who are also from AMCHP, and they're going to be addressing the questions that came through in chat, as well as any additional questions that you post in chat. Also, if you would like to offer your question or comment via the telephone, I want to invite you to raise your hand, and I will call on you. So if you look on the slide, you'll notice that there is a cutout that has our telephone number for today, and then it has a hand. It's in the upper left corner of your screen, extreme upper left corner. And if you click on that, then I will see your name rise to the top, and then I can call on you, and we'll have the operator unmute your phone. So in the meantime, I'd like to turn it over to Pia and Tegan, and let me know if you have any need for me to facilitate any other parts of the process.
Hi, Susan. Thank you. This is Pia and Tegan.
Hi, Susan. Thank you, everyone, for joining us today. We're going to start with going back to some of the questions that were submitted throughout Dr. Fraser's presentation and actually ask Mike to maybe talk a little bit more and offer a little bit of clarifying information to some of the questions. And as we do that, feel free to continue to craft and think through your questions and submit them through chat. Our first question is kind of a compilation of some of the comments that were in the box. Gloria, I think, specifically asked if you could provide your notes on the 40 different national initiatives that are currently in existence addressing birth outcomes, and then somebody else asked something about integrating across the silos and across turf. So I was wondering, Mike, if you could just speak a little bit more about specifically what AMCHP's doing to try and help coordinate across these initiatives.
Well, I think from the AMCHP perspective, we've really tried to know from a situational awareness perspective what's going on in the states, and certainly what I was trying to show with that list is not identify every individual program nationally, and we can share those, but really just show the sheer volume and the interest and desire that's out there right now to address this issue. I think from the AMCHP perspective, one of the biggest things we've done is try to make sure that MCH programs are involved at some level and offering their technical assistance or expertise where appropriate, and then in some places where they can get out of the way to improve efforts. So it's not a one-size-fits-all solution. I think that the efforts of AMCHP have really been to make sure that as we move forward with this issue, that MCH, which has traditionally been a leader and one of the few places where there's dedicated resource to address infant mortality, continue to be the leader and where that's appropriate. So I would say we've been pretty active in monitoring what's going on across the country and assuring that there's a leadership role for Title V where that exists and a partner role where that exists as well.
Great. Thank you, Mike. Sounds like everyone can continue to turn to AMCHP with questions about all those initiatives, and we'll continue to follow up with resources and be the resource for you if you have questions. We had another question from Leslie. It was more specific to the COIN project, and she was wondering what the COIN states are currently doing to work with child welfare programs. Mike, do you know anything specifically about what COIN states are doing to work among child welfare programs or specifically TANF programs?
You know, I saw that question, and it really made me think. I don't know, and one of the places where I think that there's some opportunity is exactly in that area, and especially in the states where the home visiting program is being run out of either a children's council that cross-cuts programmatic homes within a state or in the child welfare agency. And I know there's a few early childhood agencies that are administering the home visiting program. That might be a good place to ask because for us, what I know about the COIN is it's really focused on the health side, at least initially, and hasn't cross-cut into the more early childhood education, economic security, those kinds of places. So that's an opportunity for sure.
Great. We had a follow-up question from Gloria specifically about any sort of efforts that are going on to try and fund integration or integrative models across sectors, since the research shows a lot of the impact on these health outcomes is really complex and multi-sectoral. So do you know anything about conversations or current efforts to fund more integrative programs?
You know, I think the place that where we've seen that happen has been in the promising practices area, and states that have adopted and supported efforts, both state and community-wide, to create new models or to build on models that had already been established in the states. And I think that's been a challenge for folks to find models that cross-cut these various domains where we're all comfortable working. And I think an area that's ripe for more research and more investment. One of the biggest challenges of the MCHP program is the fact that it's evidence-based and relies on several models that all have some great data. But when you're working with one set of models and trying to remain consistent with implementation and fidelity across the states, it does create a challenge for places that want to innovate or involve partners that are different from the classic model or the accepted model. And so I think in that promising practices investment in the states, we may see a lot more innovation than we might otherwise if that wasn't there. And I think that's a place where there is ample opportunity, though not a huge commitment right now from what I can see.
Great. Thank you, Mike. I think we have a few hands raised. Susan, can you help us?
Yes, Peel, we've got Jill Wadnick is interested in asking a question or sharing a comment. So, Jill, would you press *1 on your telephone, and the operator will open your line. Give you another minute, a second or so. Okay. Joan Elder, I don't know if you are also on the phone. If you are, go ahead and press *1, and so we can open your line. If you are not, go ahead and lower your hand, since we won't be able to take comments through the computer. Okay, great, thanks. And Sally Baggett, go ahead and press *1.
Good afternoon.
Hi, Sally.
Hi, everyone. I just had a comment to make. We are actually running several models of home visitation out of a federally qualified community health center. And so a comment about the effectiveness of really integrating home visitation into primary health care.
Yeah, that's really interesting. That's cool.
We are running nurse-family partnership, healthy families, and healthy steps. So we have that continuum of services, trying to find best fit for family, some real obvious benefits to running it as part of a team with medical providers.
Right.
We also have behavioral health integrated in that. So just a plug for some of the integration efforts that are ongoing, but still looking for ways to fund it and sustain it.
Yeah, that's great. Can you remind us where you're from again?
Oh, I am in Greenwood, South Carolina.
Great. Great. Thanks for that. I'm sure there's a great, sort of referral process, a much easier referral process for potential families as well, being right there.
Well, there are a lot of benefits for both, obviously, for our home visitation efforts. Identifying the most at-risk families is much easier when we have access to a significant body of folks. Use of electronic health records is a real benefit. We're able to share information directly with the primary health care providers, so actually document in the records when it's appropriate. Able to get alerts from physicians when they have families that they particularly want to see involved with home visitation, sharing of concerns when we have mutual customers. Just so many advantages to having that system. And I will say that we also did this when we were not actually employees of the FQHC, but a separate legal entity. So it's very possible to do even if you're not staff of primary health care. I think too many people see it as an impossible task and put up barriers when it's actually very doable.
Right. Right. No, that's great, and you're showing that, so thanks a lot. We'll be interested in seeing how that evolves.
Thanks for sharing, Sally. And Yvette, if you are on the phone line, then we can take your comment verbally. If not, go ahead and lower your hand so we don't call on you. So do we have a few other questions that came in through chat, Thea?
We had one question about breastfeeding promotion and any sort of ways breastfeeding promotion and support is being integrated into innovative infant mortality reduction programs. Dr. Fraser, do you have any comments on that, or we can also open it up to other people?
Yeah, let's open it up, but I can say thank you for that reminder, and that's part of, I think it's not specifically stated, but it is part of what's going on in these initiatives. I apologize I didn't tease it out. But I think that's a big part of the focus on improving birth outcomes has been to recommit ourselves to breastfeeding. And there's some pretty neat opportunities within the Affordable Care Act and health reform to promote breastfeeding, both long-term and things that communities are doing now. So that really is a good reminder to include that in the future.
And I just wanted to put in a plug for the AMCHP compendium. We have a few programs highlighted in there that are specific to breastfeeding. One I can think of off the top of my head is in Oklahoma. They have a breastfeeding support hotline, I think, and we have a little bit of a information on how you can contact that program to find out more. So take a look at the AMCHP compendium for other breastfeeding ideas.
And the AMCHP compendium will be, a link to that will be sent in the follow-up email, so everyone will have access to that as well.
There was a slide with the compendium on it I was trying to find, but we'll get to that.
I think the rest of the questions are in chat right now, Pia. Do you have other questions from previous times, or do you have another question for folks?
I do have a few more questions, actually. And I think at this point we'd like to open the lines up and invite our participants to press *1 to unmute themselves so that we can hear their responses. This first question actually has to do with infant massage. And this is Christine's question. She says that infant massage has a strong history of improving general parent-child interaction and awareness of infant needs. And her specific question is, how is this area of expertise being incorporated into home visiting? So we're quite interested to know if there's anyone on the line that can answer this. Feel free to use your chat function also.
If you choose to answer by the telephone, please raise your hand so that I can call on you.
I can say I'm not aware of any. Tegan did one of the synthesis in the compendium. Do you, Tegan, know of any?
We don't have anything in the compendium yet, but if people do have good models we can highlight in there, please get a hold of AMCHP and we'll make sure they are in there.
That's a great idea. Okay, I'm going to move on to one more question then while we're waiting for folks to respond. Oh, I just lost. Let me go back up here. Christine, there's also a question here about not one single drop, which I'm actually unfamiliar with. So it's going to be a learning opportunity here. Our question is, how is not one single drop being incorporated into the pre-pregnancy message? Mike, are you familiar with the not one single drop
I'm not.
program or campaign? Is there anyone on the line that can provide us any more information about not one single drop?
I believe that was Christine Snell. Christine, was that you that mentioned no single drop? And if so, perhaps you could share with us a little bit more of that. Looks like we've got a couple of comments maybe related to that, prevention of FASD and no alcohol during pregnancy. So that must be what the no single drop is about. Would anybody like to, oh, Karen Hughes, I see your hand is up. Go ahead and press *1.
Karen Hughes from Ohio.
Oh. Hi, Karen.
Thank you. So, yes, Ohio is an example of a state that has implemented a widespread initiative, not a single drop. We call it not a single drop. Not a single drop in Ohio is an interagency effort to get the message out about no alcohol during pregnancy. So it has a multi-pronged approach to work with providers and public information campaigns and child serving agencies, that kind of thing, in order to prevent exposure to alcohol during pregnancy, but also to identify early those infants who have been exposed and get them into appropriate services to mitigate the consequences.
Great. Thank you for clarifying that for us, Karen.
Sure.
Hi, Karen. Nice to hear you.
Hi, Michael. Thank you.
Great. Those are all the questions we've gotten so far, so we thought we could transition into a little bit more of a discussion, and we have some discussion-oriented questions ready to go. So as we move through these, please raise your hand to be unmuted and share some of your thoughts if you have any to share. The first question is general. What about the presentation resonated with the home visiting work you do in your state? You can also chat your response to these questions as well if you don't want to open up your phone line.
And we know it takes a little bit of time for folks to write, so we're going to count to 30 in our heads, and that will give you a chance to think and write before we start jumping in with another question.
So maybe if we add a few more questions, people will have more to respond to and think about something to share. But we were wondering if we could hear from you and from your home visiting programs and what you've been involved with in your states related to these national infant mortality initiatives. So basically, how have these national infant mortality initiatives integrated you as home visiting programs?
I see that Gloria said that the information about the big national initiatives really resonated, and it gave her a sense of direction and how the country is moving. It's helpful to see how the dollars are following that direction. And it looks like Erica has a question about the national initiatives addressing the health needs of pregnant, undocumented women who are not covered. Are there any national initiatives to do that?
That's a great question. Mike, do you have any sort of awareness of a national initiative that incorporates serving undocumented women at this time?
Mike, you might be on mute.
Well, great. We'll try to follow up, and if we know of any agencies that are working on that, we can send that out possibly in the post-call email with other resources. But currently at AMCHP, we aren't working on anything directly related to that issue. Some of these questions kind of get to a basic question here at AMCHP. We're wondering how the home visiting programs at the states really work with the Title V program. So if anyone wants to share thoughts or reflections on that, we'd also love to hear that now at this point. So a lot of our discussion questions seem to be getting at the same thing. It's basically, we're trying to get a sense from how home visiting programs are contributing to some of these statewide infant mortality initiatives. So if you have anything you want to share, please feel free to do that now. We'll wait a few more minutes for chat to come in. Looks like we have a hand raised.
Great. So Karen, go ahead and press *1 again.
This is Karen Hughes in Ohio again. I think one of the ways that we've seen opportunities is to use not only the federal investment in home visiting, but also our statewide home visiting program, which in Ohio is called Help Me Grow Home Visiting, to we kind of consider it our army of folks on the ground to work directly with families in conveying the messages around safe sleep and breastfeeding and access to, helping to remove the barriers to access to care and following up postpartum to assure that families don't have barriers to getting to postpartum visits and all the things that are on the list. We have found the COIN list of strategies to be exceedingly helpful, and one of the things I think that we've recognized is that while in some ways we have pockets of those efforts going on in various places across the state, we still have a fair amount of work to do to make sure that all of those things are done statewide and systemically. So I think infusing all those messages into the existing systems, and as opposed to trying to fix it all with program after program after program, that has been kind of our challenge in Ohio. And I think, as one of the other people have commented already, that being part of this national initiative, I think, makes us feel in one state that we're part of a bigger effort, and that the momentum is a great opportunity for engaging non-traditional partners in some of this work. So I appreciate that opportunity.
Great. Thank you for sharing that, Karen. I see that we go ahead.
I was going to say, yeah, thank you so much, Karen. And we have had a lot of comments come in under chat. I was going to read through some of those at this point. There's no one else queued on the phone, correct?
Correct.
All right. So it sounds like in Wisconsin, the home visiting program is in the Department of Children and Families, but Katie Murphy's position links with DCF, with DHF, where I'm housed, along with the Title V. where many of these initiatives connect in Wisconsin. So Wisconsin is focused on infant mortality issues in the needs assessment period. We target communities with high infant mortality rates and have a goal of serving 75% of families prenatally. So that's great. It sounds like they're doing some work to integrate across the programs in Wisconsin. Thank you, Katie. Pam shared that in her area, they're working on an environmental scan to see what is already available and what the gaps are. And she's wondering if there's any tool that helps tease that out or guides the frameworks of this scan. So Pam, I would encourage you to look at the AMCHP compendium. There's a few organizational frameworks in there that might help in the needs assessment period, trying to figure out what sort of programs are already in place and how they address different parts of the health impact pyramid. I don't know if you have any more specific information you want to share about the types of tools or resources you're looking for. Rosemary Wilson shared that the home visitation goals in her state are included in the COIN work we call Healthy Mothers, Healthy Babies, and are using objectives from the benchmarks in the home visiting program. So that's great, and a great example of how COIN and home visiting are integrated. Rosemary, could you share where you're from, possibly in chat? We also had a comment come in from Illinois saying, in Illinois, we have Healthy Families Illinois, which has some Title V funding. The ounce of prevention is involved with ongoing training of HFI staff. Some of the programs have also affiliated doula programs, which some are based at county health departments. So they are linked to WIC and the breastfeeding peer counselors, etc. Lots of program integration within many of our Title V programs. That's great to hear, Robin Lee. Sounds like in Illinois they have some good models for integration, and I might be following up with you to highlight some of that in the next round of the compendium. If anybody has any specific questions, please raise your hand. If not, I'm going to continue reading off some of these comments before we wrap up. So Jane shared from Nebraska and Lancaster County. They utilize the Healthy Families America model with their visitation, and their home visitors are RNs or community outreach specialists. We use a curriculum called Partners for a Healthy Baby. So Rosemary from South Carolina, thank you so much, Rosemary, for letting me know how I can track you down. Shelby shared from North Carolina that home visiting funding is used to support multiple models, and the oversight of these programs fall under the state Title V Children and Youth branch. In addition, they're involved in their COIN as well and have 4 federal Healthy Start programs. So there's a lot going on in North Carolina. And Jane shared that other Title V dollars are used for some home visiting programs in some more rural areas of Nebraska. So that's all excellent. It sounds like there's a lot of coordination between programs at the state level. I'll read one more comment, and then we can think about final comments. But Karen is sharing that during their home visits and a part of their curriculum, they discuss SIDS prevention, child spacing, postpartum depression, and the dangers of smoking and other factors that contribute to infant mortality. Families are visited twice a month to discuss these topics along with other topics related to infants and their development. And Karen uses the Partners for a Healthy Baby curriculum in her state. Can you let us know what state you're in, Karen? All right, so we have another comment from Kentucky. I love how active the chat box is becoming. So in Kentucky, they have a statewide program called HANDS. And HANDS is housed in the local health department throughout the state. The goal of the program are positive pregnancy outcomes, optimal child development, healthy and safe home and family self-sufficiency. HANDS serves first-time families. Through the home visiting funding, we have been able to expand and serve more first-time families in 78 counties, as well as offer in-home cognitive behavioral therapy treatment for mothers that screen for severe depression. That sounds like an excellent model in Kentucky. So thank you, everyone, for sharing in chat. And if anybody wants to add anything else, remember you can also raise your hand or continue to chat. But I think we are exhausting people here, Susan, so I don't know if you have any final comments.
I do have a few final comments. I just wanted to check and see if Mike had any. I'm not sure if he was able to stay on the full time or not.
Yeah, hey, Susan, I'm here.
Okay,
no,
great.
just go for the chance. This is great learning for us, too, and I'm really impressed with what states are doing. Thanks for sharing that.
Yeah, it sounds like there'll be some additional follow-up from AMCHP to learn more about what great things you all are doing, so that those wonderful strategies that you've come up, the creative things, can then be shared with others, so that everyone benefits from the good work that you're doing. I want to say thank you so much to Dr. Fraser and to Pia and to Tegan. You've brought so much to the conversation and really stimulated some new thinking for those of us who are doing work with home visiting, and how we can collaborate with other entities so that we're really making a difference on the issue of infant mortality in our states and communities. Thank you again for your time and commitment to this webinar, but also to this issue. And the folks at AMCHP have also, as we've mentioned multiple times, developed this wonderful compendium of resources. It's entitled, you can't see it on this slide, but it's entitled Forging a Comprehensive Initiative to Improve Birth Outcomes and Reduce Infant Mortality, Policy and Program Options for State Planning. Long title, but it's a meaningful title. This compendium, along with a selection of other resources that I mentioned, such as web links, will be sent to you in a follow-up email. And what we're hoping is that one of your action steps as a result of this webinar will be that you will download and glean information from the compendium so it can support you in your efforts to reduce infant mortality. The last thing I'd like to do is provide you with our learning objectives for today and ask you to scan those. And you'll be receiving an email from Miss Africa Queen of WRMA with a link to an electronic feedback form. And she's going to be asking you about these learning objectives. So take a moment to scan them. Think about how these have or have not been achieved today, and so that you'll be prepared to address those questions when the feedback form comes to you. Really want to thank you for your participation today, the wonderful resources and examples that you shared with us, the great questions that gave us new things to mine were very helpful, and we appreciate that. And please keep an eye out for an announcement for our next webinar. It has not been scheduled yet, but it will be soon. And in the meantime, we encourage you to continue to go out and do good work for very young children and their families in your communities and across the nation. Have a great week, everyone.
And that does conclude today's conference call. Thank you for your participation.